Shall we start? That would be good, wouldn't it? So welcome everybody. Others people may drift in. As Bonnie has just said, importantly, this is being recorded. So if you don't want to be heard or seen, stay quiet and turn your camera off. I'd probably turn your cameras off anyway during the talks. This is the second of a series of NSFT research seminars. It's the first of the older people's one. And today we're going to be focusing on supporting people with dementia and their family and carers. Juni's going to introduce most of it, but just to remind people that the development program is quite a unique NSFT creation, which has been around for, I don't know, 5 years maybe, something like that, yeah. And it is really starting to gain traction and prove dividends. And today is good examples actually of the sophistication that we can bring to research, design and development by linking academia, patients and public and families and clinical services together. It adds a whole new dimension of sort of relevance to research. And so Juni heads up our older people's stream of research, and I'm going to hand over to her now. But just to say, at the end of it, we're going to have some questions and answers. So you can either put your hands up in the way that you've all now been well trained to do, or you can put something in the chat and I'll ask the question on your behalf if you want, if you're too shy. Okay, so we'll do that at the end when we finish. So over to Juni to introduce what we're going to talk about today.
Thanks, John, and hello everyone. Thanks ever so much for taking the time out to join us today. We're going to talk about two studies from our development programme in older people services. Firstly, for people who don't know me, so I'm Juni West and I'm a mental health nurse by background. So I've been leading the older people's development programme for about the last 4 years or so. The first study we're going to talk about is the CARECOACH study, and this is about adapting and testing an intervention for family carers of people living with dementia. And I'm joined by my colleagues from the CARECOACH team, Macy, who will introduce herself in a moment, Jeff, who is a family carer who we've been working with for the last year or so in developing this study and who is part of the study team. Sadly, Jeff has not been able to access us today because he's having problems with his email system, but he's very happy for us to talk about his experience on his behalf, and Fiona, who will also introduce herself in a moment. So I'm just going to hand over to Macy first, who will introduce herself and what CARECOACH is all about.
Hello, my name is Macy Mann and I'm the Programme Manager for CARECOACH. I'm based at the Norwich Clinical Trials Unit at UEA. And do you want me to talk about the programme now, or should I introduce Fiona? Okay, so the CARECOACH programme is a 5-year NIHR funded programme looking at an intervention to help the carers of people with dementia. And so we've only just started the programme. We started in August. And so we're actually starting the first work package, which is actually looking at the intervention, which is actually is an intervention which we've taken from Holland. So the Dutch have already got a programme where they have been developing sort of resources and also a sort of like a coaching programme to try and help people, the carers of people with dementia. And we are basically testing this intervention to try and look at it and see how we can adapt it for UK use in the UK context. So the first work package is actually looking at this intervention. So far we've translated the content, and we would like to actually recruit carers and staff to play with the intervention, to play with the resources, and just to give us some feedback of what they think of the intervention so they can develop it further in order to test it later as a feasibility study and later on as a randomised controlled trial. In a nutshell.
Shall I talk a bit about the first work package, and then Fee, you introduce yourself and talk about the sort of qualitative research aspects of that. I think the first thing that we want to do is use a method which has started off in as a service improvement tool, and it's called experience-based co-design. And it was set up by an organisation called the Point of Care Foundation, where to provide a structured way of finding out from lived experience aspects of services that could be changed or improved upon using a process called co-design. So if there was something specific about the service that was picked up through interviewing people who used the service, whether that be patients or family members, then aspects of that could be identified and shared, and then bits of the service redesigned by people in sort of co-design events, which is, so we're using that methodology but applying it and using it slightly differently for a research context to help us develop and adapt the Dutch intervention for the UK setting. Fee, do you want to talk about the introduce yourself and talk about the first part of that process?
Yeah, hi, I'm Fiona Scheibl. I'm the research associate who is working on work package 1. I'm a sociologist by background, and what we're doing is we're planning to recruit 20 carers and 20 professionals, practitioners, and undertake fairly unstructured interviews on a Zoom platform, and I'll be leading the interview. Really, it's bringing the person on, whether it's a carer or a health professional, and really, I suppose, in a way, kind of asking them to play with the app. So I'll be giving the controls of the app over to them. It's a bit like a workbook that's interactive. So for the carer, there's a set of, it's broken into about 9 modules, and each one, the first one is quite structured. So the first one's around acceptance, and then there's dealing with challenges, dealing with stress, the changing partner. And each of these modules have got a video. So I'll be just handing over the controls to the carer. They can run through it whatever way they like. Part of the work I'm working with Ruby, who's here today, and we've been trying to work out how we run the methodology with that. And really, what we've decided is that, you know, we can't anticipate how the person's going to interact with that. So in a way, we're kind of working with a metaphor of play. So we're very going to much let the person, the carer, play with the app in order to get the feedback, because obviously at the moment the videos have got subtitles. They obviously originate from the Netherlands, so everything was originally in Dutch. So what our objective really is to get people's feedback. Is this, you know, obviously I think, as we were speaking today about how the concept is really important and the practice of it is really important, because we were earlier this week at a Dementia Cafe, and some of the feedback coming across, you know, is that people initially. Hi, he's still here?
I'm just listening to a video. You all right?
Hello? I'll just carry on. Anyway, that people initially...
Hang on, what's the matter?
Hi. Anyway, that initially when a carer or a person has a significant other diagnosed with dementia, they may go into a state of shock. So it takes some time for them to get to a stage of acceptance. And what the PIB is doing really is giving people that kind of, oh, here's something maybe I could work with to facilitate my journey. Obviously, the Dementia Cafes are really important because they provide a safe space for people to go on that journey together. And I think that my understanding as a researcher, I'm not a therapist, is that what the PIB is doing is trying to provide that structure for the person if they can't get access to a Dementia Cafe, or maybe, yeah, something they can use as and when, a kind of interactive supporter that's there when they need it, when they've got the time, because that's another issue that came up. When do they make the time for themselves? Well, this app can be used on a mobile, can be used on a computer. It's adaptive. It can fit into a person's life who hasn't got a lot of free time for themselves. So this is, you know, really emergent stuff. You know, we haven't gone into the field yet. We're about to do some pilot work with people who very kindly volunteered their time as PPI contributors for us to practice with. As I said, I'm the interviewer. My colleague Ruby will be in the background observing what's going on. And at this point, you know, our work is very much to see how to observe and be with the person on that journey through the app, to learn more about how it needs to be adapted, for them to help us shape the content and the video content that's meaningful and relevant. You know, the structure's there, but it just needs some tweaking to make it appropriate to the UK environment. And then the next phase, having worked with the 20 people with a kind of significant, that could be anybody, doesn't have to be a family carer, it can be somebody who just does helps out with finances. We're not being really tight on the definition of what a carer might be. We're not linking it only to giving physical care. It's a broad, open definition of who that person, how that person interprets their relationship to the person who's been diagnosed. And then the next phase will be to work with 20 healthcare practitioners. And here it may be again to get their feedback on the content. You know, we'll have the carers or the participants' perception and input on the content, and then we want to get the healthcare practitioners' opinion on, is this relevant? What how can they help to bring it into shape, to make it appropriate to the UK context? And we, as I said, we've fortunately got some volunteers at the moment from our PPI contributors to practice with. We're not quite ready yet to go into the field, but the turnaround is very tight. We do need to bring on people and have this whole kind of iterative phase of data collection complete by April. So recruitment is imminently open, pending further approvals, so we're here really to alert you to this study and hopefully to whet your interest in it. And I've kind of said my piece really. I just won't hand it back to Macy to see if she's anything to flag up, anything else she thinks we need to flag up on the study.
I think you've covered the structure of the study very well, so I'll hand over to Juni to talk about Jeff's contribution.
Okay, thanks.
Thanks. That was a really good summary, Fee. Jeff Fennick is a family member who has been caring for his wife Susie, living at home for about the last 8 years. And she was diagnosed with early onset Alzheimer's disease around that time. And they've both been very research active throughout that time. So I know Susie's taking part in a drug trial that she goes to visit in London, and he took part in one of our other studies looking at needs of family carers. And sort of through that, he became involved in a project that we ran a couple of years ago, looking at trying to identify research priorities. So when we started our development programme, we wanted to ask people who had experience of using our services, whether they be people with dementia, older people with mental health problems, family members, and also staff working in the service, what they felt were important research questions to ask based on their experiences. And Jeff was instrumental in that process. It was a project that we ran for a couple of years, and he was very much involved in submitting research questions. And then he also, with him and Susie, came along to our consensus event at the end after we'd gone through lots of processes to narrow our enormous list of questions down. And one of the things that came up quite top of that list really was, what support do family members who are supporting a person living with dementia, what do they need to not only support themselves, but to also support the person that they're living with in the best way? And so it's sort of become an integral part of CARECOACH and the design of CARECOACH while we were applying for this study, and it was natural really that he should be involved in that. So he's joined us all the way through as a co-researcher now, he's going to be helping Fee and Ruby and Macy with some of the data analysis. So as we start to find some of the themes coming up from the interview processes, then Jeff will very much be involved in the analysis. So he's really looking forward to that. He's very sorry he can't be with us today to tell you his story from his own perspective. One of the other things, I mean, he's helped out enormously in lots of different ways, and I think he'll be joined by other family carers who will be helping us in this process. He's also been helping us write things like the plain English summary of the research to make sure our information is accessible. He's been helping with the press releases. Some of you might have seen, they came out a while ago now for CareCoach, but he helped write a case study that was picked up by various news outlets. And he's also particularly been helping facilitate time for Fee and Ruby to visit the Dementia Cafe. And I really couldn't be doing this pilot work without his help and his sort of introductions, really. And he's very... He said to me earlier, he rang me earlier because he was bemoaning the difficulties of trying to change his Outlook password, which is why he can't be with us today. But he was saying that he feels like an old hand in a way. You know, he's been in this role for 8 years, but there's things about the CareCoach intervention that's making him think, and he's able to sort of marry up what we're trying to do in the study with his own lived experience, and it's just giving him other things to think about. So he likes being involved in this process because it helps validate some of the things that he perhaps tries to do to support Susie, and validates his experience in that, but also gives him some other things to think about. And I think that's where we want the first piece of work to come from with this study is to come from that reflective place. And we want the interviews to enable people to just take a step back from the role, whether they be really busy staff working in either our memory services or our DIS teams or the community mental health teams, staff who are very experienced and have been working with dementia carers for years, just to have a moment to step back and think about your experience and how does that relate to the content of the Dutch programme. And Fee mentioned some of the topic areas like acceptance and looking after yourself as well. I think they're often things that we know intrinsically as clinicians, but we don't always have time to ask or to check out with people. So it's just about making sure that staff use their experience as much as family carers to help build this programme, so that we can try it out and test it in the UK. So Jeff continues to be involved and will be throughout the whole study, but I know that we're also not just doing this in Norfolk, are we, Macy? Do you want to talk about where else we're going to work
yes,
with this study?
Right. We'll also have 2 other sites, so Bradford and Nottinghamshire, and we've specifically chose those sites to broaden our sort of ethnic diversity. So we really want people from a wide range of backgrounds, because we want our intervention package to be as sort of accessible and as approachable as possible. And the Dutch package, although it is good, it's very white, middle class, partner related. So we're not, and Fee mentioned that it's not just the definition of carer. So it could be like the offspring, the sort of like sons and daughters, could be the sort of like friends and family. So it's not just the partner of the person with dementia.
So it's Nottingham and Bradford are the 2 sites, weren't they?
That's correct, yes. Mm-hmm.
And we're looking for younger people as well,
if possible, yes. So as I say, the range of people, so not just partners, but as I say, offspring, neighbours, friends, family members. And Fiona mentioned the numbers, so we're wanting 20 carers across the 3 sites and 20 healthcare professionals across the 3 sites.
And that could be healthcare professionals, could be support workers, nurses, medics, psychologists, OTs, anybody working, supporting family members of people with dementia in any of our NHS services, which is similar across Bradford and Nottingham as well. And after the interviews, so there will be individual interviews, won't they, Fee, to begin with, and that will take 1 or 2 hours of time.
So up to 2 hours, with as many breaks as necessary, and there will be participants will be offered a £20 gift voucher for taking part.
The other thing I was thinking about in terms of engaging with experience-based co-design, and I can only speak from a sort of nursing profession background really on this, is that I think that this type of reflective practice and working to help co-design aspects of this intervention is pretty good reflective practice for revalidation and things like that. So we are going to be supporting certificates for people who've taken part in this process, explaining which parts of the process they've been involved with, to help with that. And after the one-to-one interviews, Fee, what happens after that, Fee and Macy?
After the one, we've got a phase of the one-to-one interviews, and then there's a group kind of focus group iterative phase, and that then feeds into the co-production. Yeah.
There's a series of workshops.
Yeah.
So there was a sort of a carer, a group carer workshop, and a separate healthcare professional workshop. Hopefully, sort of 10 people in each, and then we hope to have a joint workshop with both carers and healthcare professionals. And during those workshops, they'll be shown some footage taken from the interviews, try and get touch points to actually to expand on what sort of areas are important, what can be changed, and to really sort of help the sort of focus the attention of the sort of like what needs redesigning.
Yes.
So I'm wondering if anyone has any questions about this process at this point.
So Bonnie's asked a question.
Yeah.
Can you explain a little more about what partners in balance looks like in someone? Ooh, please.
Yes. Look, it's a kind of an online workbook. It's what does it look like? It's set out in modules. So it's an interactive web page, really, is the best way to describe it. So it starts off with a set of prompt questions, and then you get to watch a video. So it's and it kind of, that's the best way I can summarize it, really, is that it's an interactive web page with a series of questions to open up around the topic, then a video, then some deeper reflexive practice with sort of vignettes of experience, case studies, to engage, perhaps, reflect back on experience. And then the final set is, or the final part of each module ends with a kind of option to email your coach. So that in reality, the person would be interacting with a health professional using the app. The email would be sent off, and then the person who was coaching them would have however many, 48 hours or so, they'd reply. So it's something that can be done in the person's own time, but at the same time is connecting them in some way to an input from a therapeutic support, a person. It's not just purely a depersonalized app. It actually kind of connects them to the human side of the support. But yeah, that's how I did. It's it's like having a workbook. If you bought a workbook or want to be a kind of self-help book, here's some tasks to think about. There are lots of them on the market about different ways in which we need to reduce our stress. So you may have seen those, but that's what this is like, really. A kind of reflective part, a video, and but the unique thing of this is that it actually does connect you to a human who's going to give you some feedback. So it's not just a kind of one-dimensional book. It's got that other kind of dimension to it, of the human interaction, which is what makes it quite unique.
Some more questions. Can I just ask these on behalf of the chat? Is it only available to carers who have digital access, and will any barriers to access be examined as part of this study?
Say it again. Sorry, I missed it.
Do you have to have digital access given the population and stuff, or and will barriers to access the digital be examined as part of the study?
This is something that we are aware of, and I think that the program is accessible sort of online, on a tablet and on mobiles. So if you have a mobile phone, sort of smartphone, then you can access it through that. And I think with COVID, people are now a lot more familiar with online video conferencing and online fora. So we will certainly be looking at whether that is a barrier. Yes.
Seems important, doesn't it? And another question: do you think the cultural differences between of the Netherlands and hereditary dementia are very different in the UK? And is a separate question: is CARECOACH or the product used quite widespread over there?
I'm not sure about how widespread it is used and how long it's been running for in Holland, but in terms of the sort of cultural context, I think that it is more white than the UK. So hence we would like to expand in sort of like more sort of ethnic diversity and broaden our sort of like context and setting. But yes, that's what, in some ways, that's what we're testing to see whether how applicable the package is and how much we will need to change from what's currently available.
Good. There's no more
and
questions.
I guess an important part of that first piece of work is about how an intervention like this may fit with NHS or health and social care services, because the role of the coach is quite important, isn't it? And so we're sort of exploring who is best placed in which service to provide or be able to provide or want to provide that sort of coaching role. So there's a second work package which looks very much at that sort of implementation aspect of this intervention, and also linking with the wider system a little bit to try and understand that.
That sounds like a critical part of what it's how it's used in the UK context by our services. Can it be all that sort of stuff? Yeah. Yeah. And no more questions if you want to.
Okay, thanks Macy and Fee. Thanks for joining us. I was just seeing if Chris has joined us, which he hasn't yet. But myself and my colleague Linda are going to talk about another study called Discovery. So I'm just going to share my screen. And if Chris comes in and joins us, he'll let us know he's here. Can everybody see that? So, the second study that we are involved with, we've just been awarded a National Institute for Health Research grant to evaluate post-diagnostic dementia support as it's being offered within the Recovery College model. And the short title for this study is Discovery. And I'm hopefully going to be joined by Professor Chris Fox, who's based at University of Exeter, but also works at NSFT in the Norfolk and Norwich Care Group Memory Service. And I'm joined by Dr. Linda Birt, who's a Senior Research Associate at University of East Anglia. Hello, Linda. So I'll ask you to introduce yourself. Is Linda here?
I'm here, sorry. I had to run and do something. Apologies.
No worries. Could you just introduce yourself, Linda? I think we're still waiting for Chris as well.
Okay, sorry about that, everybody. I thought we had a short break. So I'm Linda Birt. A research at the University of East Anglia. My research interests predominantly around older people and dementia, whether that's in the community or within care homes. I do quite a bit of care homes. Nice to be here this afternoon.
Thanks, Linda. And we've just been joined by Chris. Chris, are you here?
Yes, I've zoomed in.
Thanks for joining us. I guess it seems quite unusual to use the word recovery in the same sentence as dementia is a progressive illness. So our talk today is really about what we mean by this and why we think this topic's important to explore. So to start us off, I'm going to hand over to you, Chris, if I may, to introduce yourself and just talk us through some of the background. And I'm changing the slide, so you'll have to just give me the nod.
Oops. Okay, then that's great. So good afternoon, everyone. Yeah, what am I? Who am I? I'm an old age psychiatrist. I currently work in the city team at the Sophie Centre 1 day a week on a Wednesday. But I'm also employed since the 1st of September by University of Exeter. So there's a little bit of Devon in Norfolk now, which is a bit bizarre, but there we go. And I think you've heard about CARECOACH today. I'm sorry I was late for that, but I co-lead that with a colleague called Jane Cross. So you might have seen my name there. And then with this project, Discovery, which we're going to talk about a little bit this afternoon, I co-lead this with Juni West, and both of these projects are groundbreaking pieces of research led by the Trust, in effect, which is great, and it's been a long time coming. And this is extremely large scale, both projects, although the CARECOACH is bigger because it's got a trial, whereas Discovery is more of an evidence getting things together so we can then roll out practice. I just came from a very long meeting with NHS England on something called Dementia Connectors, Dementia Navigators and Dementia Advisors. And there's a lot of innovation there. And some of the sort of outputs from Discovery are likely to feed into that innovation. That was interesting. There was an argument about what is a navigator and what's an advisor. And I ended up very confused. So that's why you need evidence to see where where services should be and who is doing what, etc. Right. So let's go to first slide then. Juni, there we go. This is old news, but basically dementia is increasing despite our friends in Oxford saying it's actually going down through better healthcare. Inevitably, it's a consequence of age and better clinical skills and better recognition. And it's estimated that a significant number of patients are growing in the ethnic minority and also more early onset. This is mainly in the early onset, we think, an ethnic group, through better services within reach into these services and recognising these patients, whereas before perhaps there was a longer delay in diagnosis, but it's not 100% clear if that is the reason. The other thing we all know is that receiving a diagnosis can be pretty life-changing, and often that's a piece of work. When you tell someone they've got a diagnosis, part of the post-diagnostic work is to sort of consider it's not just a death sentence, which many people fear. And it's interesting when you diagnose, I think it might be, and then you come back in a few months to see me. When they leave the room, or commonly with me, they say, well, at least it's not dementia, doctor. And you have to think, well, when they come back and see me, I'm going to have to prepare the ground, because they then, before they arrive, they tell you that that would be awful for them, and you have to say, well, I'm not ruling it out. So therefore, you know, it is clearly a sort of, can have a major impact. But as we know, you can live very well with dementia, and that's part of the role of recovery colleges and other initiatives. There is a stigma, and this is some local work, which is the negative connotations. I see the sort of story, you know, this week with patients saying to me, I don't take my husband to the dinner parties anymore because he can't say anything, or he says silly things and it's embarrassing. So we either don't go or I go on my own, which is sad to see. But it's how you manage that. And that's things like where CARECOACH and other projects may well help with that. Next slide. It's a bit slow, teams, isn't it?
That's the next one. Sorry, it is very slow from my end.
So we've worked for a few years developing the concept of recovery colleges in dementia. And recovery colleges are well known in adult mental health, have been for some considerable time. It's been championed by somebody called Professor Slade, who's doing an evaluation of adult service recovery colleges. And part of the issue with recovery is, what is recovery? And about 15 years ago, there was quite a famous paper review published by Surrey, which is one of the first reviews I've seen, with the concept of you can recover from dementia. And it really is, what do you mean by recovery? Because for medical, we mean cure. Whereas in this concept, it can mean, well, recovery can mean you can change your life, you can make small changes in your family network. It's not the same as the medical definition of recovery. The other thing that we've drawn a hand out in the development of this work is that there are negative attitudes in society about dementia and aging, and often people feel they have to stay in their houses because they feel that society doesn't understand them. And that's where dementia-friendly communities have tried to address this. It may, hopefully, it continues, although the sort of publicity around that has sort of switched off somewhat to an extent. So one wonders how that's going to keep going. I think the idea of empowering people and communities to support those with illness and the networks is critical. You can't rely necessarily on the health service, social care, or private companies. There has to be some also partnership, and beyond politicians, with the public themselves, and the responsibility has to also involve them to an extent. And these are huge issues that society is considering: how much we invest, the impact of pension changes, the triple lock, etc., financial post-COVID recovery. What do we do about the care home deficit? What do we do about the huge social care deficits? These are things that everyone can have a think about, not just the people with dementia and their families, but also offspring, children, relatives, and other members of society. It's very important that we prepare for the future, because dementia, although Biogen would have us believe that they've cured it, whatever the drug does, if it ever gets approved, it's unlikely to be a complete cure for the vast majority of patients. It will be work for a sort of slowing down for a limited number of people. Therefore, at present, we can't really see a game changer disease modifying medication or intervention that will change things over the next 10 to 15 years, perhaps. Beyond that, who knows? Next slide, please. So the other thing about diagnosis and recovery is the whole post-diagnostic consideration. I've talked about some of my sort of reflections with patients, with the dinner parties, etc. And you have to be quite careful with the way you communicate with people, because people often say to me, I don't want to end up dead in a care home. You know, I've seen the awful stories, or I want to drive, I need to keep driving, how can I get my independence? All the issues about finances, and also then we've got issues of wills and worrying about financial abuse of families potentially or not, which can occur, and also the whole stigma about it's an illness, it's out there, it's common, it's not rare, but you're not dangerous. You can live very well with dementia for many years. You can live in the community and be content. And there are services out there, both voluntary, statutory, etc. So there is, but it's about mapping that, which is critical. And that's again where recovery can be helped by entities, perhaps such as the recovery colleges. The other thing that I love is the concept of prescribed disengagement. And this still occurs sometimes, and it's difficult in services because there's a huge demand, massive waiting lists in certain services. Staff are overrun. Post-COVID, social care has been put under pressure so that they have limited support they can provide. Where do people go? The charities are rebooting their systems, but it's clearly there is still a gap. And there was data from last year where they did a survey just before, it was a survey a few months before the pandemic started, national survey for the PRIDEM programme, which is led by Newcastle's, and that found that there was huge postcode lotteries in what post-diagnostic support was available. What happens in Essex is not the same as in Yorkshire, it's not the same as in Northumberland, it goes on and on and on. And there's still a huge pressure on, well, what is there? You know, what can I expect? It does seem massive variations, sadly. So the prescribed disengagement is still sadly in existence, although there are initiatives trying to overcome that. The problem with all this disengagement is that if you don't get anything, then you retreat, and then you just have you're with your GP for crisis management. The GPs often think struggle themselves with lots of demands with patients, their comorbidities, and also they think that dementia may explain the heart attack, and that can occur with people thinking it's all dementia when in fact the physical illness then doesn't get adequately managed, partly because of skill set, education, and system overload. It's not deliberate, it's just a sort of system issue, which is where taking ownership, learning about the illness, learning about how you can self-manage better through initiatives such as social prescribing, carer support, and perhaps recovery colleges may well sort of lead to people knowing when they need to go for help and how they can push for that if they're not getting the response they need. Next slide, please. Social connections are fascinating. This is a whole area of interest that Linda and others and myself share, because we're very interested in social prescribing, and we're waiting to hear about something in December, which may or may not arrive, about enhancing social prescribing. But that is underpins the whole idea of social linking, social connectiveness. There's interesting evidence that if you are isolated and very lonely, your cognition is worse. And there's some evidence from UCL on epidemiological cohort studies where they've shown the cognitive scores are worse if you have no social contacts. That includes social media contacts. You don't just physically see people, but it's you're isolated in your home and all you've got as company is the television, which can be very difficult and damages your cognitive health. There's also a link there with deafness, because there's a strong link now between deafness and the first signs of cognitive impairment. And that may well be linked to social connectiveness and social linking, because if you're deaf, it's hard to communicate. And therefore, it starts a vicious circle of lack of stimulation, and that therefore may accelerate the dementia and the demise or bring on the onset of dementia. So these things have a biological plausibility. It's not just about sort of theoretical or behavioural issues. There is actual biological aspects of this. And in fact, in brain imaging studies, they've shown again that people who are socially isolated have a different MRI scan with tracer markers compared to those without in certain areas. And that may well be part of the sort of process of your worsening cognition. And therefore, it may well, that potentially could be more powerful than many very expensive drugs that may or may not be approved the next year or so. Moving on, next slide. So we know that increasing participation by not just the people with dementia and cognitive impairment, but their family supporters can benefit patients, and it's the whole network effect. And in fact, we put in a bid last week for people under aged 18 who know someone with dementia to try and upskill their education, because there's a huge gap there. So there's a whole sort of system, and it's not just the individual. And also there's neighbours and friends and society members if you haven't got any relatives for whatever reason. So this living experience and socialisation and connectedness is really important. And the other thing to think about is flourishing. So part of that connectedness links to flourishing. So what is the definition of flourishing? It's quite contentious, but it's both living well, you're happy with your life, you're content, etc. There are scales for this. It does need further delineation, but if you could have there is a flourishing index, rather like there's in a parallel how cognitively impaired you are with the MMSE. And if people can do work on the Flourishing Index to show that at a certain level of flourishing, your health is X, that's a nice little link to make. There's work to be done on there, but it does feed many of the factors that we've talked about today with recovery and also social support and networks. Am I got one more slide? Yes, I have. So what is recovery? So this is the issue I talked about with medical recovery, and I'm a doctor, and I sometimes still put my medical hat on and prescription pad and think, drug, give that, pain goes, there we go, it's sorted. But that's not personal recovery, and it's quite challenging sometimes medically to think about that, although it's changing. And the idea is that it's basically in medical recovery, you focus on the disease, reducing symptoms and hospital days, whereas personal recovery is basically living well, you're content, what do you want? And I often say to people I see clinically, okay, I've got my ideas and I'm reaching for the prescription pad, but what are the 3 things you want to get out of your consultation today? And it's always about things like, I want to be happy in my job, I want to feel well, and I want my children to be happy and well. And it's that personal recovery rather. And then I say, that's fine. So how can we help you? Do you want a talking treatment, social treatment, or medication option? And you bring it together with the shared decision making. And generally, I find I get to, well, I don't know, maybe it's N of 1, but I feel people are happy with their outcome because they feel involved, but also they're taking personal responsibility for their recovery. And that kind of mixes the medical with the sort of more psychosocial aspects of what is recovery. So despite widespread adoption of personal recovery, the challenge has been to how you operationalise this. And this is where Professor Slade has led the field in social recovery colleges and developed the sort of profile and operationalisation of that. And there's the Recovery 2 trial, which is undertaking, which reports in the next couple of years or so, and that will help with that. But his team have developed core concepts of recovery, which are relevant to families and people living with dementia and cognitive impairment. So in promoting life beyond services, recovery needs a key ethical obligation. You have to consider that it needs to honour the person, their citizenship, their role in society, the networks, and it has to represent the difficulties and disabilities of the individual and how that can be best adapted to by society, but also how they can carve their sort of niche in society, despite can't change necessarily everyone else's behaviour, but it's important for the individual to feel how they can feel valued as such. And this is my last slide. I'm nodding, and hopefully Juni is going to agree with me. So this is the basis of the Recovery College model and recoveries in dementia. It's something called CHIME. I only learnt about this a few weeks ago, and I was asked to give a similar talk to this to a European group. And it's basically connection, hope, identity, meaning, and empowerment. And when I gave this talk to PhD students, there were about 20 or so there. There was someone from Holland who piped up who said that they were looking at recovery colleges, and their survey on recovery found that hope is the strongest driver of recovery in people with dementia and families. So Linda and Juni, I'm not sure, but I've just flagged that up. They haven't written it up yet. They're going to publish it at some point, but I was quite interested in that hope and optimism. They seem that is the best part of where you should aim for in your developments. Now, they might be wrong, but that's from their literature review. Kind of makes sense to me. It's got core concepts like motivation, inspiration, mindfulness, having dreams and aspirations. That then energizes the rest of it, they think. However, some people may say connectiveness is important, and it just really depends, I suppose, on what are your deficits on an individual basis. So not everyone may have hope deficits, but they may have identity or connection deficits. So you can play those up, rather like sort of pushing a lever and personalize that. And hopefully that's what recovery colleges will do in dementia. And on that point, I'm going to hand over to our speaker.
Thanks, Chris. Brilliant. That's really interesting about hope. So part of what we're also looking at in this study, which we'll cover again in a little while, is about what sorts of outcomes are going to be important for recovery colleges who are running dementia courses to measure, to evaluate the impact of their work. So that will be a good paper to look out for in our literature search. When I look at this CHIME framework, for me as a long-term mental health practitioner in dementia care, and also someone who's studied the person-centred approach to dementia for quite a lot of years using dementia care mapping, which was developed by the late Professor Tom Kitwood, I really liked seeing this for the first time, and I could see lots of lots of links really with the recovery CHIME framework and person-centred care in dementia. So it's been an interesting journey for me to sort of pick this up and see what other people have made of this. So just following on from Chris, in terms of the sort of structural look at recovery colleges and how they've impacted mental health trusts. So they've been adopted and encouraged really since 2011 by the Department of Health, who set up and commissioned a collaborative called IMROC, so Implementing Recovery Through Organisational Change. And I know there's colleagues, Karina's on this meeting, who had a lot to do with helping NSFT set up Recovery College. And the colleges really are a way, providing the structure as a way of supporting adults with a range of mental health difficulties. And they vary across organisations, but essentially recovery colleges offer adult educational courses for people who use mental health services, and also their families, and importantly mental health staff. And even more importantly is that courses are co-designed and co-run by people living with mental health difficulties who are described as peer tutors or peer supporters alongside experienced staff, mental health staff. And so NSFT's Recovery College journey, set up in 2013, really is about empowering people to become experts in their own journey with personal recovery, despite limitations that mental health conditions may be causing. And as I said before, it may seem unusual, and it may not be the right word to talk about recovery in dementia if we consider that dementia is a progressive illness. But if we apply the personal recovery concept, as Chris has described, to recovering a life after a diagnosis, and through focusing on managing very difficult symptoms whilst living a meaningful, enjoyable life, can that apply to dementia? And it's interesting that some services across England are now offering recovery college courses, or courses about living well with dementia within the recovery college structures. And they're available for people with dementia, their families, also friends and staff. So it is something that's cottoning on out there. And also it linked, this sort of thinking has sort of been many threads over many years, really. It's linked with some work that we did in the prioritisation project as well, which I'll come back to. I think recovery colleges also give mental health staff the opportunity, and quite structured opportunity really, to learn directly from people's lived experience. And people attend courses together and develop skills in co-production, so co-producing and working together to put the course content together. It's very much a shared power base. And some studies have suggested that staff involved with recovery colleges report renewed motivation and a positive impact on how they work within the organisation. So there's something there about a recovery focused organisation helps with staff motivation. And a particular note is the inspiring role of peer tutors within Recovery College, and really novel perspectives. So we can only understand what people who are living through something can tell us. And the Recovery College seems to provide that structure on a regular, embedded basis. And that's a level of understanding of lived experience that's beyond something like a patient satisfaction questionnaire. It's very much about hearing equally on a level playing field about what people's experiences are and what can help and what doesn't help. So it's not multifaceted really. When we started looking at this research bid, we could see that also the CHIME recovery framework has really relevant links, and clearly relevant links, with the NICE recommended person-centred care framework. And so NICE have talked about person-centred care as valuing people and those who care for them, and providing individualised care, but also crucially taking the lived experience perspective of people with dementia and their families, but really importantly people with dementia, and then also looking at the social connections and the social psychology around people. So it's not one of those elements in singularity that person-centered care requires all of those elements to be met. And there's been various other authors, and I'll just point you to Hammond and Debney, Laura Hammond was a research assistant with us for the first year of our development programme, and she was very interested in this. And she wrote a paper. It was an opinion piece, really, with Conrad Debney, who was a peer support worker, but who was also an experienced mental health nurse and worked with people with dementia. And they set up Conrad set up a recovery college dementia course in Norfolk several years ago. There's also links with the Royal College of Psychiatrists Memory Services National Accreditation Programme, which was known as MSNAP, and also the Dementia Strategy, which, although published in 2009, there's still lots and lots of elements that are being worked through from that. And one of their objectives was to develop peer support and learning networks for people with dementia. So there's lots of policy support for this, which is interesting. And Chris has talked a little bit about recovery college research. So the first UK college was set up in 2009, and there was 85 counted in a study in 2017, and they're in existence or developing in other countries. Yet the published evidence of impact and effectiveness of recovery colleges is fairly limited. Lots of case studies, lots of local evaluations, and some papers that I've referenced here. And at the moment, the National Institute for Health Research has funded 2 big programmes looking at the cost effectiveness and characterisation of recovery colleges in England. So Recollect 2 is the second part of that. And we will be working a little bit with the Recollect 2 team, so that's ongoing research. They're looking at recovery colleges for people with adults with mental health problems, so they're going to be linking with us a little bit because we're looking at a dementia part of that. But really, the evidence base and I guess the theory of how these work and the impact of co-producing courses and attending recovery college dementia courses is really unknown at the moment. There's been a few small pieces published and poster presentation and a case study, but other than that there's very little out there about it. So Discovery came about inspired by the work of Laura and Conrad amongst others, and looking at some of the papers and some of the policy links, and also a very inspiring group who are working in East Suffolk Care Group, who've been co-producing and working together for a number of years now with their recovery college course, dementia course. I evaluated their experiences of co-producing their course as part of a research fellowship, which I'm yet to publish, but I will let you know when I do. Linda will smile at this because it's taken me a while to write the paper. We also, when we were preparing this application, did a survey, a scoping survey, which was quite limited in what we could ask, but we did survey UK recovery colleges to find out how many other people were offering or running or thinking of running dementia courses. And 19 out of the 28 who responded to our survey said that they were either positively engaging with or planning to. So this is happening, but there is an important gap in the evidence base. So for me, it was really about lots of people are getting in a room in recovery colleges and spending lots of time co-producing, but what happens? What happens? What impact does this have on people? What sorts of outcomes are going on? Is it about hope? Is it about meaningful connections with people? And what impact does peer support in dementia have? So we thought it was well worth researching. And as I said, it linked to some of the findings from our prioritisation project, as CareCoach did as well. But in terms of discovery, there was lots of input from people about potential feelings of abandonment, shame, guilt, despair and hopelessness in people who had a diagnosis of dementia. And it was marked how many people wrote about those sorts of feelings. So we published that project, but we very much linked discovery to our findings from that. Linda, can I hand over to you and I'll to just talk through the next steps about where we got to with getting our application in and working with a group of people with dementia to help us think this through in a more structured way.
Yeah, certainly, no problem. I think Juni's rather undersold the amount of work and the length of time it's taken to get the bid developed and then successfully funded. And so it was a number of years working with public partners, so a couple, two sets of people who were living with dementia who very much supported the development of this bid. And part of what they did was to help us to think about, they'd both been involved in recovery colleges and both producing the recovery college and then delivering the recovery college course. And what they did was help us to think about what is it that happens at each stage. And therefore, if we're going to understand it a little bit more, what is it that we need to unpick, to unravel at each stage? And that helps us to develop what's called a theory of change map. And I don't know if you want to put that on next, Juni. So it's a very complicated map, and I don't intend to talk us through that today because I haven't quite got my head around it yet, if truth be told. But basically what it does from a research perspective is help us to look at each of the stages that are going to happen during the development of a recovery course and the delivery of a recovery course. And therefore it's really helped us to formulate the research questions and to decide the type of methodology, so the type of, if you like, theoretical background that underpins the work. And at each stage of the research process, because it's a 3-year study, we will come back to this theory of change map and we will start to look at distinct points. So it might be the rationale. So we've got a vague understanding of what the rationale is from the published literature so far. But one of our first things is to do what's called a realist review of that, and that will help us understand the rationale behind recovery colleges in more detail. And then when we come on, we might look at the resources. So what's actually happening in these different courses and how resource heavy or light are they? Because ultimately that will impact on whether it's something that can move forward, whether it's a type of post-diagnostic support that's going to be useful for people living with dementia and memory services. I don't know if there's anything else that you'd want to add to that theory of change map, Juni.
No, only that I was just thinking about the practicalities of co-production when working remotely. So at the beginning of this piece of work, we had set up that we were going to go and meet as a group in a cafe and drink coffee and eat lots of cake and sort of work on it on a table with pieces of paper. So unfortunately, COVID got in the way of that, but we did the best we could. So it involved lots of printing out of things on large pieces of paper, sending them through the post. And then we had a series of Zoom meetings and one-to-one conversations with people with lived experience to help us. And it worked brilliantly as within those restrictions. And I'm very grateful to the people that gave up their time to help us with this and to make sense of it.
Yeah. Yeah, definitely. And sometimes looking at it in small sections, we didn't do the whole thing in one go. I hasten to add that. So maybe if we look at the next slide. So our research questions within the discovery study are quite wide ranging, but basically we want to build on that theory of change and we want to understand what is it about recovery colleges and how can they work for people with dementia, or do they even work for people with dementia? So we've adopted what's called a realist review, which is where we want to look at what works and where does it work and how does it work and who does it work for. So we're sort of breaking it down into those components. So that means that we want to find out what it's like to attend a course. Those people who perhaps have a new diagnosis and are attending a course with their family members or by themselves. But we also want to find out, importantly, what it's like to be a person with dementia or the supporter of a person with dementia who is co-designing and then co-delivering the course. And so these people are normally working alongside somebody from a mental health trust, and they're looking at what type of materials might be useful for somebody who's going to attend the course, what type of prompts might we need, who's going to run which bits and which sections. And it's recovery colleges are very much set up as being co-designed and peer-led, and we want to unpick that a little bit more and understand, is that actually happening? If we think about power balances and how is that working in different contexts and in the different recovery colleges. Then we want to know about access, and back in CareCoach we talked a little bit about different types of access and equality and diversity in people living with dementia. And so we want to understand, is it just some people that feel that they can go, or is it a more equitable type of post-diagnostic support? And then who are they relevant for, which is very similar. You know, what are the types of people? What are the characteristics of people? Why do people choose to come to these courses? And how do they even hear about those courses? Or do they hear about those courses is also one of our questions. So you can see we've got quite a lot, but we do have 3 years to unpack it. And the next slide shows some of the ways in which we're going to do that. But in the middle of developing this, of course, we had the COVID pandemic, and that has, even since we did our original survey of those recovery courses that Juni spoke about, there's been changes. So some courses have gone online. We know that some courses have stopped running. In East Suffolk, they have been using Zoom, but if we're thinking about access and equity of access, then that throws up some things as well. Some of the colleges are hybrid, so some people are in a Zoom and some people are actually in the room, and that's something that's of particular interest to myself within a research context, thinking about inclusion and power when some people are there with the presenters and some people are not. And we want to look at whether there needs to be more work to make hybrid offerings effective, because there are some positive things to not having to travel to a course, to not having to leave your home, to being more flexible in the times at which you can attend the course. And all of these will be things that we're considering through the research, and new things since we started to write the bid that have come about. So in the first year, we're hoping to, well, no, we're not hoping, we are going to start on the 1st of January. But in the first year, we are going to do 2 key things in the first sort of 6 months. So one is another survey of recovery colleges. We want to find out what's happening now, particularly post-COVID, and hopefully try and get more responses, because we've got more resources this time than we did in our preliminary scoping study earlier. And we're also going to be contacting NHS memory services and find out whether, you know, how they're signposting to recovery colleges, their sort of involvement in recovery colleges in their areas, because it's important to note that not all recovery colleges are run by mental health trusts. Some are run by charities or other organisations as well. Then we're going to do the desk-based stuff, the theory around what's happening. So that's a rapid realist review, and it's called realist because it's how does it work, who does it work for, where does it work. And so we're going to be drawing in a lot of literature, using literature search techniques to look at what's actually going on about recovery colleges and dementia. And we could make assumptions just within our small research team, but that's not what we want to do. In the spirit of co-production and ensuring it's fit for practice at the end as well, we're going to be holding stakeholder advisory groups. So at all stages, we'll be looking at the data that we collect with key stakeholders and discussing it with them, and that will inform how we move forward, and particularly how we come to the final part of the study. And we're lucky enough to be working with Innovations in Dementia and Rachel, who will be supporting us with our public and patient involvement, and so that we have a group of public and patient partners who are living with dementia themselves. We may run a separate group for carers, we're still sort of looking at that, but we particularly want to hear the voice of people living with dementia. And we're also having what's called, I think that's our next slide, a community of practice, which is where all of our stakeholders are people that have a particular interest in not just older people, in people living with dementia in recovery colleges. And these people will form the advisory group that support us when we're looking at our data and trying to make sense of the data and its applicability to practice. I think that's really important, its applicability to practice. So you can see, I think I've spoken of most of these people, but particularly that, sorry, Juni, particularly that particularly picking up on the potential subtle differences between attending a course and co-producing and delivering a course. Thank you. So we've got the first 6 months very much is paper-based. It's getting that information in, it's getting an understanding of the landscape and the published literature, and also importantly getting our ethics in place so we can go out and do some real-world research, which is the sort of part that I'm coming in more as a researcher. So we're going to be, from that first 6 months, developing our theory of change, looking at what needs to change, and developing something called a programme theory, which, if you like, is it's a document that informs us going forward and hopefully informs practice at the end. To understand how recovery colleges are working, it's not enough just to look at the paperwork. So we're going out to do ethnography. So that's observation in recovery colleges. And we're intending to recruit 5 different recovery colleges from different places across England in order to go in and be the fly on the wall, if you like, to observe what's happening when people are talking about developing the course, when they're co-producing the course. How are those conversations going? Are they led by one party or the other party? Part of the ethnography is also interviewing people. So we'll be talking to people who have attended the course about what they thought about it. How did they find out about it? Was it what they expected? Is it meeting their goals? If we think back to Chime, you know, what did they want to get out of that course, and have they got what they intended to get? It's fine to look and it's fine to listen, but sometimes paper does provide a different picture, and therefore we'll look at documentary evidence. What was the process of co-producing that course? And that should hopefully give us that full picture to understand in each of the 5 case studies what it was that happened to co-produce the course, to co-deliver the course, and to attend the course. And also we'll be discussing our findings at different stages. So that's going to take really the bulk of year 2, I think, to achieve that. And it will involve a fair bit of travelling, we're hoping, although we will do some hybrid courses as well and look at Zoom and what's it like using a hybrid method of delivery. So by this stage we'll have a wealth of information and we'll be able to start to think about what outcomes might be important. Are they the outcomes of Chime? And it was quite interesting what Chris said about hope being important to some people. Are the outcomes of the Recovery College the same for practitioners as they are for people living with dementia, as they are for the peer researchers? And so we'll be doing another survey at this stage to look at the outcomes that might need to be measured if it's going to be a practical suggestions going forward, because obviously within practice we often have to show that something is relevant to get the funding to continue it. So personal recovery, these are things that we've discussed during this presentation. Wellbeing, social inclusion, which I think is really important. Agency, which came out of the work that we did in an earlier study I was looking at, which was promoting self-connections and social connections. And we're going to, our final work package is looking at co-producing some resources, but practical resources. So we'll be co-producing them with people living with dementia, with health workers, with carers, all of our community of practice again. And the idea is that these will be accessible to other people with dementia who may want to co-produce a dementia recovery course to health practitioners. We're not quite sure what format they're going to take yet, because that's the joy of co-production, but in about 2 years we'll come back and talk about that. And then finally, we'll use what we've learnt to really share guidance nationally and share resources nationally. So if there's trusts that aren't yet doing it, and we've shown from our research that it's something that's applicable and of benefit to somebody living with dementia, then they might be able to sort of tap in rather than reinventing the wheel, really.
That's
That's
fantastic,
my last
Linda.
slide.
Yeah, it is. Thank you, brilliant. Does anyone have any questions for us or thoughts about what we've just been presenting and talking about?
Don't forget, you can write them in the chat if you're feeling shy. Oh. Bryony.
Thanks, Jeannie. That was really interesting. Sorry if I missed this, but just wondering, either from the research or just from your kind of anecdotal experience, what generally is the reaction of people with dementia or their carers when you kind of talk about the concept of recovery? And people tend to kind of get it, or is it quite a difficult thing to kind of explain what you mean by that in a dementia context?
I guess my only experience is of just asking the group in East Suffolk what their experience of co-production was, and it did come up so I did some qualitative interviews for that, and there's mixed views actually. I think one person felt that it was a controversial term, and that using the word recovery in the course title would actually turn people away from it and make people annoyed or cross or angry or just have some sort of reaction to it. And so it was obviously something that they had all discussed together and probably had come backwards and forwards on it a little bit as well, because it was interesting that part of the co-production process involved the group themselves learning about the recovery model in order to put together their materials to get that across to other people. So they'd obviously bashed it around for quite a bit of time and woven their own experience of diagnosis and going through that process into it. So I would say that it is controversial, and I would say I'm really looking forward to finding out what everybody thinks about it when we go out and explore in the wider world.
Yeah, it'd be really interesting.
Linda, did you have anything to add to that?
No, only that the initial survey we did showed that not many of the courses used the word recovery. It was living well, which is, such a statement that's very hard to define. So that will be interesting to see what they're called and why.
Yeah, thanks.
I suppose even in physical health, though, there's Chris talked about physical health, didn't he? But if you get diagnosed with heart disease, you may well never recover, particularly if you're elderly. But there's sort of fantasy, isn't there? The doctors will fix you and you take a pill and everything will be fine, but your life will change and gradually get worse. It's going to happen to all of us. So we're all living in a state of recovery. Yeah.
I guess it's just giving people space and time to unpick the face valueness of that word and the context in which we're using it. So I find it really interesting.
Anyone got any other questions on this about anything?
Just picking up on that, Fiona, I've not put my sort of digital hand up. Is it in the kind of program theories around it? Is there any theories looking at it as a kind of process of transitioning of identity? Because I saw identity was one of the key. Does that weave into this notion of recovery, kind of rebalancing, or reconception is too grand a word, but a kind of revisioning of the self or something?
Yeah, I think that's a really good point, Fiona, and that's partly what came out in the previous study I did, the PRIDE study, which was where people were receiving and accepting their dementia diagnosis. They were doing work to reposition themselves and to maintain a sort of a strong self-identity beyond just living with dementia, or beyond having dementia, if you like. And so there was that sense of presenting a self that's beyond being that poor, sad person with dementia, which is what some of the stigma is still around.
Yeah, thanks. And then did you also mention, I had a question about is it their peer talk courses? So that is somebody who's living with dementia who teaches the course, yeah? That's really exciting, yeah. Okay, thank you.
Think about it, I do like the idea of recovery. I do like the fact there's something attempting to attack it rather than just living with it and coping with it and making the best of it, and you know, which is what all of us are doing in life, isn't it, really? Yeah. That's good. Oh. Any other questions, anybody? Come on, come on. You can type it and I'll read it. Silence. Okay. Shall we? Is that the end of our time, Juni? Now is that done? I just think for everyone's benefit, this to me encapsulates the development program's absolutely its best. You know, from where it started, as you described it, with people with working in the trust, having an idea and trying and then developing through to your role in leading these things, and the clinical relevance of everything you just talked about, the absolute to people's lives relevance of it, I think is it's just beautiful, really. Rather than being a theoretical exercise to try to do something which might make any difference in anyone's lives. But I like the fact it's come from the ground, it's come from the clinical front face, and it's got to this huge study, really, which is really in looking at this in detail. I think it's brilliant. Great. Well done. Should we finish there, Juni? Have you finished now? Have you anything else you want to say or to? No. So just want to thank everybody for joining us today. The next one is, I've got this right, I hope, the 18th of November at 2 o'clock, which will be children, families and young people. And we need to spread the word, those that are around. And then on the 25th, there'll be another seminar. There we go. We've got messages popping up. So I did get that right. 18th of November for CFYP, and then 25th for older people's, for adults. Thanks everyone for joining us. That was really good. Thank you, Juni and Linda and Chris and Fiona and everyone. That's great. So I shall wish you all well, and see you next time. Thank you very much.